I'm Lee Nelson. I'm going to discuss cannabinoids in neurological surgery. I'm sure that probably the majority of the room knows far more about cannabinoids than I do. I have no disclosures. I definitely am not an expert in cannabinoids, and I have no investments in the cannabis or cannabinoid industry. In 1970, there was a huge void in our knowledge as to what marijuana was, what it did, and this void still remains. Marijuana continues to be classified as a Schedule I substance, according to the Department of Health and Human Services, and the same void is still present. I was going to start with a slide for those who are marijuana or cannabinoid naive, namely myself. Does anyone know the difference between marijuana and hemp? The marijuana and hemp are actually the same species of plant. The only difference between marijuana and hemp is that hemp plants are grown for industrial reasons and have very low concentrations of THC, but it's actually the same species of plant. Does anyone know what a phytocannabinoid is versus an endocannabinoid? A phytocannabinoid is a plant-derived cannabinoid. These are the cannabinoids that you see in marijuana, namely THC and cannabidiol. There are a huge number of additional phytocannabinoids in the plant, and I didn't want to get into those today. It's quite an extensive list. Endocannabinoids are cannabinoids that are produced naturally in the human body. And so we have an endocannabinoid system within our own body, and we produce 2-racodonyl glycerol, 2-AG, and anandamide, AEA is shortened versions of those. And then we have receptors for cannabinoids in our bodies. So the human being has cannabinoids in it, and there are cannabinoid-specific receptors in our body. CB1 receptors and CB2 are the ones best characterized. CB1 receptors are located kind of throughout the brain. None are in the medulla, and this is the reason why it's rare for you to have a breathing problem or some kind of horrible difficulty when smoking marijuana, because it doesn't affect the medulla. There are, in contrast, opioid receptors in your medulla that cause you to quit breathing, and this is why if you take too many opioids, you do quit breathing and you die. CB2 is a type of cannabinoid receptor, and it's located primarily on immune-related cells in the human body. So it's kind of exciting. We have an endogenous cannabinoid system in the human body, and we have receptors that occur naturally in our body that these act on. And so this is why people get so excited about marijuana, because they think that, oh, we have these normal receptors for this drug. We co-evolved with this plant, and so they get very excited about it. And research into cannabinoids is expanding exponentially, and there is evidence that cannabinoids actually can be effective as an adjunct treatment, not as a primary treatment, but as adjunctive treatment in refractory epilepsy, in MS, controlling pain and spasticity, and in chronic non-cancer pain. Chronic pain is one of the primary indications for that's reported by medical users. There's numerous studies that show this, and cannabinoids act through CB1 and CB2 specific mechanisms to suppress pain on spinal, central, and peripheral levels. According to state registry data, chronic pain is one of the conditions that there is substantial evidence for its efficacy, and there is substantial evidence. There's a large body of evidence that they can help with pain. Most of that evidence is modest. So substantial in this sense means there's large quantities, but the impact on pain is in fact modest. And most of the evidence really that's published is for neuropathic and or cancer-related pain. And I'm not going to talk about cancer-related pain in the discussion today. I think an oncologist might be probably better qualified to talk about suppressing cancer-related pain with cannabinoids than a neurosurgeon. I wanted to focus on the neurosurgical data. We'll go to the studies. I'm changing my screen here that I'm looking at. I have a different screen than you guys, so I apologize. Let's go to the studies. I think this didn't get changed, but my presentation did. Here we go. So this is a study actually out of Israel where they're doing a lot of research, and I wanted to focus my talk on the studies that deal mostly with neurosurgical pain. So this is a prospective open-label study. There was no control group. There were 206 patients with various chronic pain conditions, and they looked at these patients. 24% roughly of them had radicular or low back pain. And the symptoms had been present for 3 months prior to starting the study. And these patients had been trialed with first and second line analgesic drugs. And the median dose of cannabis that they consumed was 43.2 grams plus or minus per month. And the drug was supplied mostly as cigarettes. The outcomes of this study were pretty good. The pain symptoms improved in this patient population in roughly 66% of them, so 2/3 had a benefit in pain. This was a little concerning. 26% the pain got worse. Did anyone expect that? That's sort of interesting. Statistically, there was significant improvement in various quality of life domains in these patients. And so they felt better, they were sleeping better. 44% of them were able to decrease their opioid therapy. That's wonderful. And they decreased their median dosage from 60 to 45 milligrams. Unfortunately, this did not reach statistical significance. And their physical disability scores, interestingly, did not change. So what does that mean? You feel better, you're doing better, your quality of life is better, but your physical disability score doesn't change whatsoever. The authors felt that possibly when they're smoking pot, their pain wasn't necessarily improving, but their perception of their pain was improving. In other words, they remained disabled from the pain that they were having, but it didn't actually help their disability. And this is a difficult study because while these things are very encouraging, I'd like to point out that 1/4 of them had pain that got worse while taking the drug, and 5.3%, so a really small number had to discontinue therapy because of side effects. And then the other critique of this study was that there was no control group whatsoever. So it's hard to make a medical conclusion when there's no control group. This too was another study done out of Israel. Israel doesn't have open marijuana laws, but they do allow for medical marijuana. And the growers of marijuana there, I think there's 9 different growers in Israel, and they supply these studies. They are doing a lot of research in Israel on marijuana, and this is another one of those studies. This actually was a terrific study in that it's looking at patients that we care about in particular. This is 46 patients. They had sciatica due to spinal stenosis or disc herniation or failed back syndrome. And this is a very interesting study because they had failed 12 months of treatment prior to entering the study. And they had failed at least 2 narcotic drugs. And they were then given medical cannabis. The exact content of the THC was not controlled. So while the number of growers available in Israel is limited. They actually don't know the concentration of the THC in what they gave to the patients. So what did it show? This is another great study because it had a long follow-up. There was a statistically significant improvement in the brief pain inventory, the visual analog scale, SF-12 scales, and an active range of motion. So they actually were able to move much better. And 59% of them did return to work. So this is totally exciting. You think, well, this is clear-cut evidence that smoked marijuana can lead to improvement in these patients in the neurosurgical patient population. Unfortunately, though, this study is limited because there was no control group whatsoever, and so it's hard to say that marijuana was the cause of this. For instance, they could continue taking their narcotics while they were in the study, so it's hard to say this is truly just due to marijuana. The other critique of this study was that no one has any idea how much THC was actually being delivered. This is another study that looked at the combination of spinal cord stimulation in patients with spinal cord stimulators and the use of cannabinoids in the treatment of these patients. It was a very small number. You'll notice that only 11. The patients continued using their spinal cord therapy, and this was a good study in the sense that these patients, this is done out of Italy, by the way, these patients had to stop all of their analgesic drugs prior to starting the study. And this was a pretty good outcome in that if you'll notice, their mean pain rating score reduced really very significantly from 8 down to 4.7 on the visual analog score. And they had improvement in brief pain inventory items, and there were no real adverse events. Unfortunately, as well, though, this study lacked a control group, and so it's hard to make real conclusions from it. But you bring it up because there's study after study like this that shows that there's a benefit, but it's hard to get high-quality data. Let's go to the next. So in our effort to get high-quality data, I wanted to bring up this study. Now, those were individual studies. This is a systematic review and a meta-analysis of many studies. In this case, this is a review that was published in 2015. It looked at 28 randomized controlled trials, which are the best kind of trials, and it included different types of synthetic and plant-derived cannabinoids for the treatment of chronic pain. And they concluded that there is moderate quality evidence to support the use of cannabinoids for a modest, meaning a 30% reduction in pain, and a modest average reduction in pain score. So you have a modest reduction in pain if you use cannabinoids. In this case, most of them were synthetic, looking at these studies. A few were plant-derived. And if you could say that your pain is better, or there was a 30% improvement in your pain, you qualified for that modest reduction in pain. But I would point out to you, even in this study, notice that it was 37% in the group that got the cannabinoids versus 31% in the placebo group. So it did reach statistical significance. So I don't want to take away from that, but that's not like a panacea. This is not the solution for chronic pain that we're all looking for. If a placebo, 31% of the people in the placebo groups got better, and 37% in the marijuana groups got better, you can make this statement, but it's not like an overwhelming result. And then the modest average reduction in pain scores was 0.46 on a visual analog scale. So if you had a pain of 8 prior, your average reduction was 0.46. You went down to a 7.5 on average. So we're not talking about a cure for chronic pain. And this is one of the more powerful studies because it's actually doing a meta-analysis on a huge number of 28 randomized controlled trials. This was another wonderful review published in Pain, and this came out last year's 2018 study, and this looked at 47 randomized controlled trials and 57 observational studies. They were looking at chronic non-cancer pain, mostly neuropathic and MS-related. Very few of these studies included neck and low back pain conditions. And the result was kind of similar in that cannabinoids, in 29% of patients, they reported a 30% reduction in pain. This is a huge number of trials now. Look at what placebo was. So 26% of patients on placebo had a 30% reduction in pain. Now, there are people in here invariably that suffer from chronic pain. And this isn't meant to take away from your use of cannabinoids or how you use them personally, but the data, when you do randomized controlled trials, is there. There is evidence that it does do some good, but it's not overwhelming. It's not like we've cured pain. Let's go to the next slide. I don't think this got updated, Sagita, with I had a few more comments, but I don't want to misspeak. So conclusions. There are a few clinical trials that evaluating back pain, and they suffer from very major methodological limitations, including variations in the substances, doses administered, routes of administration. But there is evidence that cannabinoids offer pain relief to those who are suffering from chronic pain. The evidence is a little bit better over the short term than a sustained benefit, and there's also evidence for an increase in adverse events. More studies will be required to understand the true cost of cannabinoids and whether or not those costs are overcome by the benefit. And their back pain, without question, needs to be studied more. I'm struggling because my note slides and these slides don't line up. There's also been this question is, can you use cannabinoids? And I don't know for any of you that were here last year, we had a speaker that talked about this in particular, was using cannabinoids as an alternative to opioids. And there is evidence and studies that say since we started allowing a more liberal use of marijuana in the U.S., there's been a reduction in prescription medications for opioids. And is cannabis an alternative to opioids? This retrospective survey by Bonke, I believe this is out of Ann Arbor, in 2016, looked at medical cannabis for chronic pain. And what they found in that study was that 64% reported a decrease in opioid use, and 45% reported an improved quality of life. And there was also a significant correlation between the reduction of side effects as you reduce your opioids in this study. And so that does suggest that maybe this could be a consideration. They do act, however, through different pharmacologic mechanisms, and I wanted to make a couple of comments about this. There has not been a single randomized controlled trial in the United States looking at cannabis as a substitute for opioid addiction. There's not a single randomized controlled trial in the United States substituting cannabis for opioids in patients who are taking or misusing opioids for the treatment of chronic pain. So those studies have not yet been done. The only individual study to look at this issue was actually published in the Journal of Addiction Medicine last year, and they found, quote, that medical cannabis was positively associated with greater use and misuse of prescription opioids. So this is published data saying that if, according to the Journal of Addiction Medicine, that medical cannabis, I'm going to repeat this because it might come up on the ARS questions. Medical cannabis is positively associated with the greater use and misuse of prescription opioids. The American Journal of Psychiatry, in another study published in the fall of 2018, notes that cannabis use increases your risk of developing a non-medical prescription opioid use and opioid use disorder. And so it is irresponsible for a healthcare provider to say that the use of cannabis or medical cannabis is a reasonable substitute or an alternative to opioids, and this is based upon published data. Malignant gliomas. Yeah, this is the slide I wanted to get to. So Meghan McCain, I believe, is on her morning show. She came out and said that medical marijuana could have saved or prolonged her father's life. And the question is this a true statement? So let's look at the data. There's a huge amount of laboratory and research data that suggests actually that cannabinoids might be very useful in reducing tumors. They're anti-angiogenic, they're anti-metastatic, they're involved in apoptotic cell death and arrest of cell cycle using our endogenous cannabinoid system. And so there's a huge amount of research data that suggests that cannabinoids should be able to have an impact on cancer. Unfortunately, there's not yet a clinical study that demonstrates that cancer survival rates are altered whatsoever with cannabinoids. Do we think Meghan McCain was right or wrong in saying what she said? We still don't know. Let's keep going. This is an interesting study out of Britain. It was a pilot study where they looked at infusing THC into the patients with glioblastomas. So these patients had glioblastomas. They put a subclavicular reservoir, and they would simply inject THC suspension into the tumor itself. And what they found was, based upon imaging characteristics using MRIs, that those patients that had this treatment, they did have a temporary reduction in tumor proliferation in 3 out of the 5 patients. Unfortunately, in this study, the median survival time was exactly the same for these 9 patients. It's a very small study, as patients who didn't receive the treatment. This isn't a controlled study. They just wanted to see if it does anything at all. So survival was really the same, but they saw some radiographic benefit. This next study is probably the study that was the basis of what Meghan said about her dad. And this is a study out of Great Britain looking at Sativex, which is a 1-to-1 THC and CBD drug that is being developed by GK Pharmaceuticals. And they did an open-label phase 1 study with 6 patients where they treated with temozolomide, which is our standard drug for GBM, and combined that with THC and CBD. That was deemed safe to do. And then they followed it up with a phase 2 study looking at 21 patients. And this was incredible, looking at the results. Overall median survival in the patients who got their drug, so this is a company-sponsored study, their survival was 662 days versus 369 days for those that got placebo. The survival at 1 year was incredibly different, 83% versus 44%. They did see that there was a severe treatment emergent events in 50% of the investigational group and 44% in the placebo group. They were more moderate in the placebo group. But this was the exciting data out of this study. And I think this is one reason why neurosurgeons are going to be very interested in cannabinoids and their ability to possibly help patients with this disease. But I would point out to you that this isn't yet published peer-reviewed data. This is from a company that's spending money to develop this drug, and they didn't provide, and this is simply a poster, so they haven't provided the genetic evaluation of the tumor types that they were treating, and this has not yet been subjected to phase 3 trials, and so the jury is still out. But the point being here, this is what Meghan McCain based her statement on. And in view of this sort of weak data, she probably was right. Maybe Sativex could have prolonged her father's life. I wanted to go backwards. Let's see if I can. So I just wanted to stop and ask you. So there may be some benefit of treating your brain tumor. We don't know that. But treating your brain tumor with cannabinoids. Who of you in the room might consider smoking pot or using cannabinoids now, knowing that it might help treat your brain tumor? If you don't have a brain tumor. So is there anyone that's going to start smoking pot who doesn't yet have a brain tumor? But you want to smoke pot because you know that it could help you with your brain tumor. Is there anyone that's willing to raise their hand? I'm just curious, because this kind of data is precisely the kind of data that you'll encounter on the street. Oh, it probably helps with brain tumors, so I'm going to smoke pot to prevent a brain tumor. I might point out to you that temozolomide and radiation therapy to the brain actually do help treat brain tumors, but I don't think anyone in the room would sign up for brain radiation in the absence of a brain tumor. So I just am anticipating what can happen. And in fact, guess what we looked at? It turns out that if you smoke pot, you have a modestly increased risk of developing a brain tumor. So, and it's a 2.8-fold increased risk. Now this is, a small number of people out of this 133,000 participants got primary gliomas, but when they looked at it, they had a modestly increased risk to develop gliomas compared to non-users. And this is for those who smoked just once a month. So I don't think that it would be wise to take the data that I just showed you and use that as a justification for your recreational marijuana use, because in fact, it might increase your risk of a brain tumor. So, when you go into a pot shop, this is an ad, or if you look online and you have a spinal cord injury, these are the kinds of ads that you'll find. 5 cannabis strains to help you with spinal cord injury. So let's look at the data on spinal cord injury. This is another pretty interesting study. Is a double-blind, randomized controlled crossover study with a reasonable number of patients. And what they found in those with spinal cord injury, they looked at a couple of things here. They looked at neuropathic pain from spinal cord injury, and they looked at spasticity. And what they found was actually a little bit of benefit of both. The more important finding here was that there was a statistically significant pain reduction of greater than 30%. That, again, is considered modest pain reduction in those taking THC. Notice placebo got 45% response, but THC, the low-dose THC got 70%, and the higher-dose THC got 88%. And so in those with spinal cord injury, there's some evidence to suggest that that THC can reduce pain. They did see in this study as well that spasticity reached clinical significance after 3 hours after the second dose, but that was only with the 2.9% THC. So if you wanted improvement in spasticity, the lower dose of THC was better. So going more is not always better. Another study. This is another study looking at the treatment of spasticity with THC in those with spinal cord injury. And they did see in this study that THC, in this case they were using only synthetic THCs, and there was an improvement in spasticity symptoms. Interestingly, 23% of these patients reported an increase in pain. This is actually something that has come up in that other data that I showed you, but there's a number of patients who use cannabinoids who have hyperalgesia. In fact, in this other study, let me go backwards. This other study didn't look at this explicitly, but yeah, in this study, they found that the heat pain threshold was, even though it helped with pain, it did not have an impact on your heat pain threshold. And you say, what is the point of that? It's unlikely that cannabinoids will change your actual pain threshold. So it's not so good for postoperative immediate acute pain or any acute pain that you're having, as opposed to opioids, which can be kind of useful with acute pain. THC and cannabinoids are probably not useful in changing your pain thresholds. So spinal cord injury summary, I know I'm running out of time. Cannabinoids show promise in the treatment and the sequela of spinal cord injury. The benefit does appear pretty modest. It's not a panacea, but the morbidity of spinal cord injury is really so significant that most patients would welcome even a small improvement. But it's important to recognize that that benefit does come with risks. The gentleman that I'm operating on Monday that has a complete spinal cord injury, he uses marijuana daily, and he says that it helps. Without question, that's anecdotal. It's not meant to be data here. But so there's also a lot of data that suggests that cannabinoids are very protective for your brain. They reduce the inflammatory response, reduce free radical damage, they decrease vasospasm. And so it's possible that cannabinoids and pot might help you if you sustain a head injury, and I'm going to show you some data in that regard. Knowing this, that marijuana might help you with a brain injury, is there anyone in the room that might want to start smoking pot to help in the event that they suffer a brain injury today on the way home from the conference? Does anyone want to raise their hand? Good, we've got one taker right here. She's going to start smoking for this benefit. I respect that. I like that. Well, the downside of this approach is that if you do smoke pot, you have a much higher risk of suffering a traumatic brain injury. So while you might be high as a kite, and if you are high as a kite, the data suggests this Wynn paper in 2014 shows that you may have decreased mortality. By the way, that was seen both with alcohol and methamphetamine as well. Those patients that are drunk or on methamphetamine also have a lower mortality associated with their injury. You have a much higher chance of getting an injury. We did study this. Interestingly, this is a multi-center placebo-controlled phase 3 trial published in 2006. I'm out of time, so I'm going to get in trouble here. But it turned out that they did this study. Look at that N number, 861 patients. They would give a single IV 150 milligram dose of dexabinol within 6 hours of injury. And there was really no difference in outcome in these patients. So we have studied this, and there's not yet proven clinical benefit. Mom, are you sure your marijuana use is purely medicinal? So cerebrovascular disorders, like with head injury, In spinal cord injury, there's actually a large amount of basic science research that's been done on cannabinoids that suggests that they should help you with stroke. Stroke volume should be lower, less damage to the brain when you have a stroke. And so there is data to suggest that it's helpful. Unfortunately, cannabis users have a higher risk of stroke. They have a much higher risk of hemorrhagic stroke and ischemic stroke. When they have a much higher risk of rupturing their aneurysm in their brain, and when they rupture their aneurysm, they have a much higher rate of delayed cerebral ischemia, which is one of the major reasons of morbidity and mortality after aneurysmal rupture. They have a much higher hospital mortality and a worse outcome. This is with ruptured aneurysms. So there's three things I'm showing here. Hemorrhagic strokes, which are brain bleeds. There's regular strokes, ischemic strokes, and then there's ruptured aneurysms. Cannabis is bad for all three of those. I'll try to go quicker. Again, the rates of you suffering a hemorrhage in your brain is higher if you use cannabis. Your risk is 1.11, and in young adults especially. So if you're a young person, your relative risk of suffering a spontaneous bleed in your brain is 2.45 times greater. That's 245% more likely to suffer a brain bleed. Users had a higher in-hospital mortality, so actually more of the users in this study died in the hospital, but they actually had fewer complications. So kind of a mixed result. Their mortality was higher. More of them died in the hospital, but they had fewer complications. Prior cannabis use is associated with a better outcome after intracerebral hemorrhage. So this is a different study. If you are smoking pot or you have a positive pot screen on admission, these patients tended to do better, and there can be a lot of reasons why. But the point is it increases your risk of having a hemorrhage in your brain, but if you do have a hemorrhage in your brain, you might do slightly better if you're THC positive. So again, it's hard to suggest that people should go out and start smoking it. Another syndrome that I just have to mention super quickly is reversible cerebrovasoconstrictive syndrome or multifocal intracranial stenosis. This is a kind of a new entity that is associated with pot use, where young people are getting ischemic strokes. And this is well documented. This is actually out of, I believe, our CU conclusions. I have to recognize there's a powerful therapeutic potential for phytocannabinoids and cannabinoids in a number of neurosurgical diseases. There's a lack of human trials. There's limited evidence to support or really deny benefits, and further studies are needed. Of note, I actually, last week, I was hanging out with all the bigwigs in tumor treatment, the guys from MD Anderson. The chief of MD Anderson Neurosurgery, I was having dinner with him, and then Raymond Sawaya, who now is no longer the chief there and stepping down. But they actually, even though they're like probably one of the leading world institutions and world leaders in glioma therapy, they absolutely had no idea that about this Sativex study and the treatment of brain tumors with marijuana. They're in Texas, so maybe that's why they haven't heard that much about it, because they can't use it down there. And this is one more thing to point out: cannabis use disorder. Patients, this is according to DSM-5, I believe, is the source of this. Patients with cannabis use disorder display physical symptoms, craving, withdrawal, use-induced psychosocial problems, so they're acting bizarre and people think something's going on with them. Or they have increased drug use and/or drug-seeking behavior. 1 out of 10 people who ever use cannabis will develop this. And 30% of all current users endorse consequences consistent with cannabis use disorder. So it's not a benign drug to use. It causes a lot of addiction. And this is Dr. V speaking to a family in the emergency room. Well, if it's any consolation, toward the end, he was high as a kite.